Colleagues, dear Chairman, dear Felix, first of all, I would like to congratulate or to thank the organizing team for organizing this very good meeting. My first slide is about stress test in real life. I don't know how many of you came by flight to Berlin, but you know we have a very good tradition with stress testing in Berlin that was announced in many papers that we had a successful stress test of the BER. Of course, you all know that the predictive value of that message was nearly zero, and we still cannot say when you will arrive, during which Congress meeting or Symposium meeting you will arrive on BER. Just I think when we talk about stress testing, I feel a little bit lost in that imaging session, because when you think about stress testing, you can either think about pharmacological stress or physical stress, but the most or the best data on that are data on cardiopulmonary exercise. So I'm going to concentrate on data with exercise testing. So what's the rationale behind exercise testing in congenital heart disease? Of course, it's patients with congenital heart often have impairment of their functional capacity preoperatively, postoperatively, and long term. And the reason for impairment may be the primary cardiac problem, but also the treatment, like the surgery, the intervention, or the medication. We have heard a lot of that. And hyperactivity leading to detraining may also be an important factor. And the exercise testing, of course, provides objective information about the functional status of heart, lungs, and peripheral muscle, like illustrated in that graph that you all know. So it's a more holistic approach on functional status and outcome of what we see in patients with left heart problems. So the benefits of exercise testing in CHD would be evaluation of specific pathologies, like indications for surgery, therapy, or additional tests. I'm going to tell you something about that. Evaluation of functional postoperative success is very important information. Diagnosis of pathology disease. Assessment of adequacy of therapy, that is stressed like later on in coarctation, for example, with patients with hypertension. Assessment of risk factors for future complications, motivation of patients for further exercise or weight loss, and instillation of confidence in children and parents, especially with the problem of overprotection, and assessment of physical capacity for recreational, athletic, and occupational recommendations, which we are going to hear a lot of, I think, in the later session from Alfred Hager from Munich. So I'm going to concentrate a little bit on exercise capacity and on predictive values. And I'm going to concentrate on coarctation and aortic stenosis, which was also stressed or was also discussed in the earlier sessions. So I would like to start with that brilliant work from the group around Gerhard Diller, where they tried to create lesion-specific data on peak exercise capacity. They used the peak VO2 as a marker of maximum exercise capacity. And what you can see here is that although we have quite good access, or we are in the upper group with coarctation and aortic stenosis, this is the mean value of the patients tested. Those patients reach only 80%, around 80% of the predicted VO2 peak VO2 compared to normals. So there is restriction in cardiopulmonary in exercise capacity, and that is not only the peak VO2, which is a parameter which relies on maximum effort. You can also measure with other parameters, which is shown by this publication from Rosalind Boyce from Leuven. So you have the ventilatory threshold or the oxygen uptake efficiency slope, or also this parameter. And those are parameters which are not so dependent on maximum effort. I would like to cite a study from Alfred Hager, which was published in 2008, from patients with coarctation, and this is the same message that they investigated peak workload in that group, and what they found in their patients, they were 30 years old, operated at an age of 11, and the majority of those patients on that side had a peak workload that was below which was below normal, and the cutoff value was 80%. And that was also that the effect in that group was not related to surgical results, meaning, for example, residual stenosis. As you remember, those were older patients operated on later compared to how we would do it now, as discussed also in the earlier sessions this morning. And you can see that were also patients after coarctations, they were evaluated with the age of 8 and had a surgery very early, and they perform during that quite normal compared to the control group, which was ASD patients. That was also peak workload that was investigated. So in younger children, operated at younger age, which was also a message from this morning, there is no reduction of exercise capacity. So if you speculate on what causes exercise, what causes reduction in exercise capacity, there might be an influence of heart rate reserve. So we have data that show us that chronic incompetence is a feature in patients with coarctation, and that was significant in that investigation from Hannover, that patients with coarctations develop over the age significant amount of chronic incompetence. In that group, patient with aortic valve disease, there was no association, so I have to conclude from that peak VO2 and chronotropic incompetence are correlated, so that might be a factor. That is, what does it tell us from clinical outcome? That is a paper from Gerhard Diller, which shows, that was in a group of GUTS patients, which were all kind of GUTS patients, and that showed that is what they measured was the heart rate reserve, and if the patient cannot augment his maximum heart rate less than 50 beats per minute, that was the group with the highest probability of death from any cause. So it is also related with heart parameters of outcome. Chronic incompetence is a factor which is involved in this. So I found this paper on on aortic stenosis. I was talking about coarctation until now, and that is a paper from the Boston group where they investigated patients which have been they investigated peak VO2, and those patients have had balloon dilatation at a very early stage. And what you can see here, also in these patients, exercise capacity goes down over the years. So there is also inverse correlation to testing age. You can see this also in aortic stenosis. So now I'm going to concentrate a little bit on predictive value. This is a work from Cincinnati that was recently published, and they tried to establish exercise testing as a screening tool for borderline residual coarctation in children. And what they found is what you always see, as I'm going to show you later. Exercise-induced hypertension is a common feature in those patients, even at that young age, operated with 6 years. And they measured also the trans-ischemic peak gradient, as well as the right arm to ankle systolic blood pressure difference. And those were patients who were normotensive during rest and did not have any significant arm to ankle residual gradient. And what they found is that when they put them in the MRI later on, that all the single parameters like transischemic Doppler gradient at rest or at exercise were not predictive to identify residual coarctation, but a combination of right arm to ankle blood difference more than 20 millimeters of mercury and the transischemic gradient of more than 40 millimeters of mercury was able to predict residual coarctation, which was then seen in the MRI later. So that might be a tool if patients have a very low gradient at rest and even below 20 millimeters of mercury to identify residual stenosis. Coarctation, repair, and outcome. We have seen the work this morning from the group around from Dr. Hijazi, and that is an earlier work from the 19th where they could show survival rates of 84% at 20 years of follow-up. But what was intriguing in that study is that coronary artery disease in all the patients with repaired coarctation was the main or the most common cause of late death. That was found in the patients who later died in 25 to 66%. So exercise testing in those patients may be a very helpful screening tool for coronary artery disease. We have to keep that in mind. So we have talked about hypertension in patients with coarctation and hypertensive response to exercise, or also called hypertensive response to exercise after coarctation repair is a common feature you can find. And that is the same work from Alfred Hager I already cited. And those were this patient group. And 28% of those patients had an hypertonus under exercise, meaning 2 standard deviations above the expected values from normal population. This can happen also in very much younger patients, as this was published just recently in Cardiology of the Young. And what you can see here, with patients with a mean age of 12 years, there was 16% of patients who had a maximum exercise systolic blood pressures above the 2 standard deviations. So all of these patients, of course, were normotensive at rest. And this is a work from the group around Barbara Mulder in adult patients again, which shows you that exercise-induced hypertension may play a role in the development of later hypertension. They investigated at 2 points, at baseline and then after follow-up of 6 years. And what they found, that these patients which had an exercised hypertension, which were normotensive at rest, developed in 46% of those patients developed hypertension later on. A cutoff was relatively low with 200 millimeters of mercury. This is debatable because this was higher in other studies. So what the authors suggest, or they pose the question if we should consider early prophylactic antihypertensive treatment in that coarctation patients with exercise hypertension. This is a slide I received from Professor Batz, also from the Leuven group. That is a multi-center study of patients where they try to determine determinants of chronic systemic hypertension in coarctation patients. And those patients, I just want to show you, which is a similar finding which we heard already today, that there are risk factors for the patients who develop hypertension, because those patients were follow-up, and then at the second time or after that follow-up, they were analyzed in multivariate analysis, and age of surgery was a factor for development of hypertension. We heard that the surgical technique was a risk factor, and male gender, as I showed you. But was more interesting for me, it was that not only peak systolic blood pressure in a multivariate analysis with receiver operating curve analysis was correlated with later development of hypertension. Also, the ventilatory efficiency slope above 27 was associated with later development of hypertension. So that could be cutoff values which we have developed also for which you have to develop for also younger patients to see who is at risk for developing hypertension. So is that a risk factor, or does that mean anything? I would say yes. That's just a work where they investigated, or they put patients in the MRI after doing a stress test or an exercise test, and what they found that there was a correlation between left ventricular hypertrophy, which is this parameter, left ventricular mass to volume ratio, and there is a correlation in that patients who have positive hypertensive reactions to exercise, and that is a pretty good correlation. And you have to know that this parameter, or this concentric hypertrophy, represents a concentric hypertrophy and is a well-validated risk marker in adults for increased cardiovascular morbidity. And that may play a role in hard endpoints, as we've seen in adult patients which had exercise hypertension. Those are all papers from patients who have no coarctations but exercise hypertension, and they have worse outcome with hard endpoints when they have exercise hypertension. So that may play a role, and this is an important finding. I just looked into the guidelines from the AEC. Does exercise testing play any role in the guidelines? You know that that was already said. A gradient of more than 20 millimeters of mercury may be an indication for an invasive or for a procedure, but also pathological blood pressure response during exercise. So I'm going to concentrate my last slides on aortic stenosis, and those are all adult data. You know, the risk of sudden death in patients with aortic stenosis is relatively, the natural cause is relatively long. You have a good outcome, and when you get symptoms, things get worse. And I just want to show you that exercise testing may be a very good tool in decision making. That was a 20-year-old female patient, and we she was asymptomatic, had a gradient in the Doppler gradient of a mean gradient of 40 millimeters of mercury, a normal ejection fraction, and when we put her on the exercise test, she developed this pathologic ST segment. So she had no symptoms at rest or at exercise, but that is clearly an indication for surgery, and I'm going to show you why that is. Those was the first one of the first studies in adult patient published, and they had endpoints like sudden death or development of symptoms in daily life, and that were all patients which had severe aortic stenosis, but they were all asymptomatic. And nearly 2/3 of those patients were symptomatic during exercise tests. And if you take a hard endpoint like sudden death in the follow-up, three patients who died developed symptoms during exercise, and only one patient had no symptoms but ST segment depression. So what this says is that the positive exercise test in adult patients with aortic stenosis is mainly driven by symptoms. This is also the graph to that work from the Brazilian group, and they show that a positive exercise test predicts worth outcome, and that is an indication for operation. And that was then confirmed by this meta-analysis of 7 papers, where they did the same like I just showed you in that last paper. Symptoms during exercise, decrease or insufficient increase of blood pressure, or ST segment depression. And what they found, which is a very helpful information, that they had no complication. And that, again, that were patients with very severe aortic stenosis. They had 3 patients who developed non-sustained VTs, which didn't need any intervention. And what they found that normal stress test associated with a low risk for cardiac events. So the negative predictive value, if you have a negative stress test for sudden cardiac death in adults, is 100%. The negative predictive value for any cardiac event is also very good, but the sensitivity is not so good. That means if you have a positive stress test, you may not predict if this patient may have an event. So the author concluded from that study that the most important findings of the meta-analysis are symptom-limited stress testing is safe in asymptomatic patients with severe aortic stenosis. Normal stress test results predict reduced risk for adverse cardiac events compared to abnormal findings, and no patient with normal stress test results experienced sudden cardiac death. And that is also an important information, that the 1-year risk for adverse cardiac events in patients with normal exercise test results is considerably lower than the surgical risk for AV replacement or AV surgery. Exercise test. Is there an additional, or does echocardiography help? It may help, and this was investigated by this group. The highest risk for developing an event in, again, asymptomatic patients with normal standard exercise test. They had no symptoms, but when they had a resting gradient over 35 millimeters of mercury, or an exercise gradient more than 20 millimeters of mercury, they were at the highest risk, and they had a 9.5-fold increased risk for an event. So I'm going to close my talk with because all those work has been incorporated in the guidelines. AV replacement is indicated in asymptomatic patients with severe aortic stenosis and abnormal exercise test showing symptoms on exercise clearly related to aortic stenosis, and this is an 1C indication. AV replacement should be considered in asymptomatic patients with severe aortic stenosis and abnormal exercise testing showing fall in blood pressure below baseline, 2E, and AV replacement, and that is relatively weak, may be considered in asymptomatic patients with severe aortic stenosis, which have an increase of mean pressure gradient with exercise over 20 millimeters of mercury. So I will close my talk by making some conclusions. Exercise capacity is reduced in older patients with repaired coarctations, as well as in patients with repaired congenital aortic stenosis. And we should develop more and more reference values for exercise limitation. They should be applied for each specific lesion, age, maybe also gender. The degree of exercise limitation is related to time of repair and duration of follow-up. Exercise testing may be a useful screening tool for residual coarctation. Exercise testing in coarctation patients delivers predictive values for the development of hypertension and associated cardiovascular morbidity. And last, in patients with asymptomatic aortic stenosis, exercise testing is used for risk stratification of cardiovascular morbidity and timing of surgery. Thank you very much.